Next topic, next session, there is something related to what we had in our medical school days. This is something very special, especially to me, because all the four speakers are either my batchmates or my like seniors in medical school, Trivandrum Medical College, and those who are chairing, Dr. Benny and Dr. Arun, are also my very good friends and are my seniors or my batchmates in Trivandrum Medical College. So let me invite Dr. Benny PV, is the Professor of Community Medicine, Google Medical College, and Dr. Arun Nair, is the Senior Consultant Psychiatrist, Medical College Trivandrum, to chair the sessions. Over to you, sir.
Thank you, Dr. Shabir. The next session is on back to basics. Actually, we have to refresh most of the topic on our basic knowledge regarding the clinical skills. Today, this is I think this session will be helpful for refreshing our knowledge regarding our basics. First topic is ECG changes in common disorder. I welcome Dr. Arun for introducing Dr. Arun Gopi.
Yes, thank you very much, Benny sir. It's a great privilege for me to introduce my dear friend and junior at Trivandrum Medical College, Dr. Gopi, who I had already mentioned as the most brilliant young doctor of our generation. He is the director and head of electrophysiology unit and heart failure clinic at Metro International Cardiac Center. He was formerly assistant professor of cardiology in Pillai Medical College. He is a product of 1998 admission batch of Medical College Trivandrum with gold medals in medicine, surgery, pediatrics, and ophthalmology. He is a winner of the Young Investigator Award on his paper on mitochondrial mutation in long QT syndromes in the Asia Pacific Heart Rhythm Society Conference of 2012. He also holds the Fellowship of American College of Cardiology 2017 and Fellowship of the European Society of Cardiology 2018. So with great pride, let me hand over the mic to Dr. Arun Gopi for his presentation on ECG changes in common disorders. Welcome, Arun.
Yeah, thank you. At the outset, I thank Shabi for this opportunity, and it's really an honor and privilege to be to have my beloved senior Dr. Arun as the chair as well, and it's again coming back home to the basics. So I'll try to share my slides. Yeah, so at the outset, I would just have a disclosure. This is a topic on which I would have dealt my at least 7 to 8 years of my academic career on, and so 15 minutes would just be be too short to do some justice to this topic. So I would just carry on, and I request the chairs to just let me know when my time is up, and I can stop at any time actually. So ECG, as you all know, gives us tremendous amount of information. This small piece of paper which records the summated electrical activity of the heart gives us a lot of information on diagnosis of both cardiac and extracardiac disorders, provided you analyze this strip of paper in a systematic way by looking at the rate, rhythm, and each of the individual waves and understanding what is going on. To start off, let's look at acute coronary syndrome, where ECG forms the cornerstone of diagnosis of acute coronary syndrome. We all know that people who have a non-occlusive occlusion in the coronary, in the form of unstable angina, you find abnormalities predominantly in the repolarization pattern, especially as peak T waves, flattening of T waves, T wave inversions, or ST depression in varying magnitudes. Generally, this indicates subendocardial ischemia and generally do not translate to Q wave. But once you have occlusive thrombus, you tend to have a Q wave and an electrical window in the heart, which translates as a ST elevation myocardial infarction, which is the more fatal of all forms of acute coronary syndrome. Whenever you have an occlusive thrombus in the coronary, generally it starts off with having a prominent hyperacute T waves, which becomes very prominent, followed by elevation of the J point, which is nothing but the junction between the QRS and the ST segment, which is generally a convex elevation followed by inversion of the T waves, and gradually as the infarct progresses, the patient starts developing electrical window in the heart, which is seen as a Q wave on your ECG. There are some objective definitions for these criteria for having, you call it an ST elevation. You should have more than 2 mm or 2 millivolt elevation in leads V1 to V3, or more than 1 mm elevation in any of the other leads measured at the J point in 2 or more contiguous leads. To call it a pathological Q wave, you need to have a Q wave which is more than 25% of the corresponding R wave, or a duration which is more than 30 milliseconds in leads 1, 2, AVL, AVF, or V4 to V6. Majority of these larger infarcts are associated with corresponding or reciprocal ST depression in the other vascular territory. For example, this ECG, as you see down, we have ST elevation in the anterior leads and ST depression in the inferior leads, which actually indicates remote ischemia or evidence of large infarct. This is actually the classical evolution pattern of an acute coronary syndrome or an ST elevation MI that you see on the ECG. The first change is nothing but a hyperacute or a prominent T wave, which is followed by elevation of the J point or a convex ST segment elevation, which is the pathognomonic feature of a massive infarct. As the infarct progresses, the height of the R wave gradually comes down, indicating the viability of the myocardium going down, and Q wave starts developing, and T wave, which gradually inverts. From here on, it can evolve in 2 patterns. One is if the area becomes non-viable and aneurysmal or dyskinetic, this ST segment elevation can persist beyond 6 weeks, which is synonymous of LV left ventricular aneurysm. Or if the infarct is resolved, the R wave although loses its height, and they form a QS pattern with a T inversion in the evolved phase of acute myocardial infarction. The T inversion gradually over time becomes upright and leaves behind only a QS pattern, which is a signature of old myocardial infarction. So this is the classical evolution pattern if you follow these patients sequentially with serial electrocardiograms. For interventional cardiologists like us, this gives us a lot of information not only on diagnosis but also to localize the culprit artery when you're dealing with a case of ST elevation myocardial infarction, because it gives us the vessel to target when you're doing a primary angioplasty. On the other hand, for ST depression, it does not have any localizing value. For example, if a person has an ST elevation in lead V1 to V4, it indicates an anterior wall myocardial infarction, and most probably the culprit artery is going to be a left anterior descending artery. If you have ST elevation in leads 1, AVL, V5, V6, it indicates a lateral wall infarct, and it most likely the corresponding culprit vessel is going to be the left circumflex. If you have ST elevation in leads 2, 3, AVF, it indicates an inferior wall myocardial infarction, and likely the culprit artery is going to be a right coronary artery. This is a case scenario, just the typical, you have QS with convex ST segment elevation and inverted T waves in leads V1 to V3, synonymous or pathognomonic of an evolved anterior wall myocardial infarction. Not only it gives us information that the culprit artery is going to be the left anterior descending artery, also some other features on ECG like evidence of right middle branch block or ST elevation in lead AVR along with V1 to V4 indicates a proximal LAD occlusion. If there is ST elevation in both V1 to V4 and ST elevation in the inferior leads, it indicates a distal LAD occlusion. While if neither of these things are there, it localizes the site of occlusion to mid part of the left anterior descending artery. This is another example where you have ST elevation in lead 1, AVL, and V5, V6. As we saw earlier, if you have elevation in ST elevation with Q waves in lead 1, AVL, V5, V6, it corresponds to a lateral wall infarct, and likely the culprit vessel is left circumflex artery. The other infarct that we commonly see in our clinical practice is the inferior wall infarction, where you see ST elevation, evidence of Q waves, and repolarization abnormalities in lead 2, 3, and AVF with reciprocal changes in the anterior leads. When you have seeing a patient with inferior wall myocardial infarction, always look at the rhythm, because most of these patients are complicated by AV blocks, which can be complete heart block to even a minor degrees of first degree heart block, as was seen in this case, which had a proximal right coronary artery occlusion, which was opened up by revascularization. In all cases of inferior infarct, it's always prudent to have right-sided leads. That is nothing but a similar leads like V4R and V3R on the right side of chest. You look for evidence of right ventricular myocardial infarction, which might complicate about 40% of cases of inferior wall myocardial infarction. And as seen in this ECG, you will have ST elevation in V4R and V5R, which is synonymous, V3R and V4R, which is synonymous with diagnosis of right ventricular myocardial infarction, which clinically presents with cardiogenic shock and clear lungs. And so in persons with inferior wall myocardial infarction, you know that either the culprit artery is going to be right coronary artery or left circumflex artery. ECG also gives us clue to look at which artery is likely to be the culprit before we take the patient to the cath lab. For example, in an inferior wall myocardial infarction, the extent of ST elevation is more in lead 2 than lead 3. If the ST elevation in lead 3 is more than lead 2, if there is evidence of complete heart block or any evidence of significant AV block on the ECG, or if there is evidence of right ventricular myocardial infarction on the ECG, all these are very specific for right coronary artery to be the culprit behind the elevation in the inferior leads. On the other hand, if the ST elevation is more than in lead 2, more than lead 3, and you have corresponding depression in lead 1 and AVL, it is very likely to be involving a dominant left circumflex artery. One other myocardial infarction which is very commonly missed is a posterior wall myocardial infarction. This is precisely because we keep our leads on the anterior chest wall and you don't find any form of ST elevation on these anterior leads when a person is having a posterior wall myocardial infarction. To be more specific, in these cases, it is ideal that you keep some leads on the posterior chest wall, which we call V7, V8, and V9, which in these cases will classically show Q waves, ST elevation, and inverted T waves in V7, V8, and V9. But in cases where you don't keep these leads, the corresponding anterior leads, especially V1, V2, and V3, will show mirror images of the corresponding changes that are expected in the posterior leads. So the mirror changes of a Q wave is going to be a prominent R wave. The mirror change of an ST elevation in the posterior lead is going to be an ST depression, and the mirror image of an inverted T wave is going to be a prominent upright T wave. So if you have a prominent R wave, ST depression, and a prominent T wave in V1 to V2, this is very pathognomonic of posterior wall myocardial infarction, which might be seen in a left circumflex occlusion. It is not only useful for diagnosis of ST elevation or non-ST elevation myocardial infarction, it also gives us an idea about the therapy that we give. 90 minutes after a therapeutic intervention or a pharmacological therapy with streptokinase or a thrombolytic agent, if you find a more than 70% resolution of ST segment changes, it is very specific for a complete opening up of the culprit artery. In addition, you can find reperfusion arrhythmias like axillary radioventricular rhythm in about 50 to 70% of cases when you are taken up for primary angioplasty. So it not only helps us in diagnosis, but also helps us in understanding whether our therapy is getting effective or not. We are always taught that ST elevation is an entity which is considered to be fatal and with ominous prognosis. You see this patient who came to us with significant angina and in a near hemodynamic compromise. On contrary to what is expected, we find ST segment depression all the leads, and if you have a close look, you can find actually ST elevation in 2 leads which we don't talk to about much, that is AVR and V1. If you have these global ST segment depression with ST elevation in AVR, this is the worst form of myocardial infarction the patient can have, and that is why he is having severe angina with crippling hemodynamics. He has what we call a left main artery occlusion, and in this case, unless we immediately take him to the cath lab and open up this left main artery, this is a case with almost 100% fatality. On the other hand, if you have ST elevation across all the precordial leads in a relatively seemingly stable patient, this is a benign entity, what we call as pericarditis, where you have a concave ST segment elevation. As I said, in myocardial infarction, you have convex ST segment elevation. In pericarditis, you have concave ST segment elevation. In different vascular arteries, you will have ST elevation in inferior and anterior leads without reciprocal ST segment changes. And the most specific sign of pericarditis is to have PR segment depression in all the leads except for AVR and V1, where you have PR segment elevation. So pericarditis has global ST segment depression with no corresponding T wave changes, no Q waves, and absence of reciprocal changes indicate that this is a benign entity which is pericarditis and needs just anti-inflammatory treatment. There are spotters on patients presenting with acute coronary syndrome. If a person comes with this kind of EKG to your OPD, this is something very obvious. If you have, this is called T waves, where you have upsloping ST segment depression with a 1 millimeter J point depression with very tall, prominent, hyperacute T waves in V3 to V4, which is called De-Winter's T wave, and it is a very sure shot sign of proximal leg occlusion and carries ominous prognosis, so should be taken up for early invasive strategy. Other thing which has to be noted is if a person comes with typical angina and very prominent T inversions in V1 to V3, this is called Wellens pattern and is very specific for a critical proximal radio occlusion, and 2/3 of these patients can evolve into an anterior myocardial infarction anytime, so needs an early invasive strategy. Whenever you see this prominent T wave inversion, you need to look at this T wave inversion specific. If you have an asymmetric T wave inversion with a steeper upslope, a terminal positivity, and a J point depression, this indicates a repolarization abnormality secondary to left ventricular hypertrophy, while an ischemic T wave inversion will be symmetric, will not have a terminal positivity, or will have a corresponding ST segment elevation. So moving on from acute coronary syndrome, the other entity where ECG is very clearly diagnostic is arrhythmias. This is the classical sinus rhythm where you have a normal P wave followed by a normal PR segment and a normal QRS. In people who have an accessory pathway connecting the atrium to ventricle, you tend to have a very short PR interval, a slurred upstroke of the QRS, and a wide QRS, which forms a triad of what we call as Wolff-Parkinson-White syndrome, that there's an accessory pathway connecting the atrium to the ventricle, and they are predisposed to various forms of supraventricular tachycardia. If you have everything which looks like a sinus rhythm, a normal P wave followed by a normal PR segment and a normal QRS, the heart rate is less than 60, it indicates sinus bradycardia.
Arun, your slides are not moving.
I think there's some
None of the slides, it stays there.
Is my slides moving now?
The last slide, what is staying there is the pericarditis.
Okay, so I think we have discussed with acute coronary syndrome, and since there's shortage of time, I'm not, because rhythm disorders itself is a big topic on itself. I'll just get out by just saying one common thing that most of the physicians should be knowing, that is where ECG is very specific, is an electrolyte disturbance, what we call as hyperkalemia. So I'll end up with this entity where ECG is sure short of diagnosing an electrolyte disturbance without even looking at the serum potassium values. So when you have a ECG which shows a very prominent hyperacute, like prominent pointed T waves with absence of ST segment, gradually as the hyperkalemia worsens, the ST segment goes off, the P waves flatten out, the PR prolongs, and you have what we call sine waves. And the beauty of this entity is the ECG changes actually closely correlate with the potassium levels. Like if you have potassium levels which is more than 5.5, you have tall prominent T waves. As the potassium levels goes above 8, you have absence of P waves. So there's a clear correlation of ECG to the biochemical potassium values, and so that is why these electrolyte disturbances can easily be spotted out on the surface EKG as well. So when you have tall prominent T waves, if it is very symmetric narrow based and pointed and tending, it is hyperkalemia, while if you have symmetric broad based and not tending, it is a sign of ischemia, while if they are asymmetric and not narrow, it is considered a normal variant. So I think ECG in various disorders, I can keep on going on, but in the interest of time, I'll stop here saying that ECG is a wonderful diagnostic tool, a very cheap diagnostic tool, which gives us tremendous amount of information for diagnosis of not only various cardiac disorders, but also various extracardiac pathologies, provided you have a systematic analysis of this paper. I'll stop here. Once again, thanking Shabir for this opportunity, and this is why I'm here. He's been close to me for the last 22 years, and this is our batch get together. And I conclude by having a silent moment of prayer for all the families who are suffering because of the numerous tragedies we are going through, be it COVID, landslides, or the plane crash we had yesterday. Thank you.
Thank you, Arun, for that excellent, very elaborate, very illustrative, illuminating presentation. Any questions from any of the participants? We have 1 minute for a brief discussion. Any questions directed to Dr. Arun Gopi about this topic?
Actually, it's difficult to deal with ECGs in 15 minutes, actually, yeah. So, and again, each of these topics can be dealt with for days together. So, I'm anyway happy if if any of you could get some points across. I'm sure it was quite a rapid presentation, and I hope there's some take-home messages from this. Thank you.
Okay, thank you, Arun. It seems nobody is in a mood to ask any questions. Anyway, thank you very much for your excellent presentation as always. And over to Dr. Benny PV to continue the.
Next topic is chest X-ray interpretation, which is that topic is dealing by Dr. Rajathilakam. She is a very close friend of me, and she is an assistant professor of Department of Pulmonary Medicine, Government Medical College, Kollam, and did graduation from Medical College, Alappuzha, and MD, DNB from Medical College, Kottayam, and also DM from Calicut Medical College. Now we are in the era of COVID. We know most of the diseases of public health importance like pulmonary TB and very common pandemic like COVID is affecting the primary system is a respiratory system, and chest X-ray interpretation is one of the most basic tool we need to diagnose most of the problems of COVID and also the public disease of public health importance. To deal with that topic, I direct the mic to Dr. Rajathilakam. Welcome you.
Thank you. Thank you very much for the nice words. And thank you the organizers for giving me a chance to present the topic. Straight away going to the topic. So I will start with how to read a chest X-ray. First we have to check the name, date of birth or age, and check the orientation, position and side description, whether it is in the left, right or erect position, AP view or PA view. It's important because the left side is marked. And in dextrocardia also we can miss the dextrocardia if the side is marked and not marked right. Like that, in PA view, the X-ray beam falls in the posterior aspect of the patient, and in the AP view, the X-ray beam falls in the anterior aspect of the patient, and usually in the supine position it is taken. And it is very important to know the inspiratory film or expiratory film. Usually this is taken in the inspiratory view. Inspiratory view, the 10th rib till the posterior end of 10th rib can be visible, and in the expiratory film only the 8th till the 8th rib is visible. So for this in the expiratory film till the 8th rib is only visible, and there can be an apparent cardiomegaly also. And check for the rotation of the film. It can be measured by the distance from the medial end of each clavicle to the spinous process. We have to draw a vertical line in the spinous process and the medial end of the both the clavicle, right and left clavicle, and the distance should be equal. If it is increased in the one side, it is rotated. And one should barely see the thoracic vertebra behind the heart. So this X-ray is a little more penetrated, over penetrated film. We have to barely see the vertebra behind. And one needs to see both, identify the costophrenic angle and the lung epicus. Here, so the X-ray should be like that. The costophrenic angle and lung epicus should be clearly seen. And in a normal X-ray, this is a spinal processes. Can identify the trachea. Trachea can be traced to lower level. This is the carina, and the carina angle should be between 60 and 100 degree. And this is the bronchial bifurcation.
Please check this slide also. Actually, is it the right slide?
Yeah, ma'am. Please kindly tell whether we should change the slide or not, please.
It's not seeing this normal chest X-ray slide. I am seeing the normal chest X-ray slide.
Which one you want, ma'am?
This is 9th slide.
9th slide, okay. First.
Okay.
In the 9th slide.
From this.
9th slide. Okay. This is a spinous process. This is a trachea. Trachea can be traced to the left and right bronchi. You can see the carina here. Carina, the usual angle is 60 to 100 degree. And if it is increased, there can be this hilar mass, this carinal mass can be there. This is the tracheal bronchial bifurcation. This is the left bronchus, and this is the aortic knob. This is the aortic knob, and this is the hilum. And this is the hilum, and this is the posterior and anterior ribs. This is the right atrium, and this is the diaphragm. This is the breast soft tissue shadow and the gastric air bubble. So this is the normal X-ray. And the 10th slide, this is the airway. Airway narrowing can be seen here. It's seen usually you can see the airway narrowing. This is the airway narrowing, and you can see this in croup or tracheal stenosis. And the next slide, ensure trachea is visible in the midline. Usual position of trachea is the midline. Trachea gets pushed away from the abnormality, example in pleural effusion or tension pneumothorax or mediastinal mass. In this, this is due to the mediastinal mass, trachea is pulled away from the abnormality. And this trachea gets pulled towards the abnormality in case of atelectasis or collapse. This is the 12th slide. Atelectasis or collapse, and in fibrosis and in pneumonectomy, trachea usually pulled towards abnormality. And this is the 13th slide, view of carina. I already said that it is an angle between 60 and 100. This is the, you can see the foreign body here, mainly in the right bronchus. Foreign body here in the right bronchus. Foreign body, we have to check whether there is any foreign body in the X-ray. Next check. So the bones and soft tissue should be checked. The bone here, here we can see the fracture bone. This is the 6th posterior rib is fractured. So in every X-ray, you have to see the whether there is any fracture of the bone, ribs or clavicle or scapula like that. Next. Here subcutaneous emphysema. We can clearly see the here the subcutaneous emphysema and some foreign bodies in here. So if in every X-ray we have to see whether there is soft tissue also should be seen. Soft tissue, there can be subcutaneous emphysema. It can be there. Next slide, please. This is usually the cardiac angle. It is 50%. Usually less than 50% is a cardiac this cardiac thoracic ratio. And if it is less than more than 50 to 55%, it is borderline cardiomegaly, and more than 60% it is cardiomegaly. You have to measure the distance. We have to draw a line, vertical line, at the maximum distance from the right and left side. And this is the cardiac ratio, thoracic ratio. So cardiothoracic ratio is less than 50% usually. Next slide. This is the anterior axillary fold. Sometimes can be there can be confusion with the pneumothorax also. We have to trace the anterior axillary. This is the anterior axillary fold. We have to trace this line. Trace this line. So this is coming outside. So this is the anterior axillary fold. Same in case of this also. This is the anterior axillary fold. Next slide, please. This is cardiomegaly. It's usually seen in cardiac failure and pericardial effusion. It's a water bottle like heart. Next. Next.
Next.
This is the mediastinum. Mediastinum is anterior, middle and posterior mediastinum. You will divide the mediastinum into 3 parts. Anterior mediastinum, middle mediastinum and posterior mediastinum. Anterior mediastinum sternum to the posterior aspect of the heart or great vessels. This is posterior to the heart or great vessels and lie drawn 1 centimeter behind the anterior margin of the thoracic vertebra. Here the 1 centimeter behind the anterior margin of the thoracic vertebra. Posterior behind the posterior limit of middle mediastinum. So we can clearly see the and this X-ray anterior, middle and posterior mediastinum division. Next. This is mediastinal widening. This is a case of lymphoma. Mediastinal widening can be seen in case of this lymphoma, thymoma, all cases. Next slide. This is a hilar mass seen in lymphoma. Next. This is an aortic aneurysm. This also there is mediastinal widening, aortic aneurysm. Here the aneurysm. Here is the aortic nuptial is usually seen, the aneurysm is there. So mediastinal widening is there. Next slide. And this is pneumothorax. You can clearly see the collapsed lung margin. Here is the collapsed lung margin. And this is the pneumothorax. Next. Pleural effusion. You can see that there is a homogeneous opacity. Homogeneous opacity here, and this is a moderate. This is an example of moderate pleural effusion. Next slide. And blunting of the costophrenic angle can be seen there. This is a pseudo tumor usually seen in cardiac failure and all. Trapped fluid collection within the fissure. This is the fissure. Smooth or lenticular contour is there. This is the pseudo tumor. And the pleural plaques, this is a pleural thickening. As you can compare the right side and left side. Here the pleura is not thickened, but here the pleura is thickened. Usually the pleural thickening is more seen in malignancies, mesothelioma and metastatic disease. This is a case of mesothelioma. This pleura with the pleural thickening. Next slide, please. This elevated hemidiaphragm. You can see usually the right diaphragm is elevated slightly, but elevated hemidiaphragm is usually seen in diminished lung volume as in restrictive lung diseases, some case of phrenic nerve palsies, eventration of diaphragm, subphrenic abscess, hepatomegaly or splenomegaly. This can be seen in elevated diaphragm. And pneumoperitoneum. This is a case of pneumoperitoneum, that is in cases of perforated viscous, that is in post-operative cases, trauma and peritoneal dialysis, this pneumoperitoneum can be seen. You can see the air shadow here. Next slide, please. This is a chilladity sign, colon between. You can see the hostrations also. This colon between the liver and diaphragm. Here the liver and here the diaphragm, and the colon is in between there. The hostration is also seen here. This is the chilladity sign. Next slide. We can divide the lung fields into three usually: upper zone, mid zone, and lower zone. Upper zone is this is the first anterior rib. This is the second anterior rib. So we can draw a line below the level of second anterior rib, and above that is upper zone. Here the fourth anterior rib. Here the above the this line. In between is a mid zone, and this is a lower zone. So second rib lower side and fourth rib lower side. So you can divide upper zone, mid zone, and lower zone. Next. The position of upper lobe, right upper lobe in lateral view and the PA view. This is the right upper lobe position, and then this is the right upper lobe in lateral view. Next slide. This is the right middle lobe, and this here in this here is the right middle lobe. In the right middle lobe, when there is collapse, there will be a triangle. The shadow will be like a triangle. Next slide. This is the collapse, right middle lobe collapse, and this can be seen here. Here the collapsed segment, the right middle lobe collapse segment can be seen. Here there will be collapse of the middle lobe, a triangular shadow. Okay, next slide. Here is the right lower lobe, and in the lateral position, the right lower lobe here. Next slide. Left upper lobe with the lingula. This much portion is with the left upper lobe with the lingula. And here in the lateral position, left upper lobe with the lingula is this much. And left lower lobe. We have to identify the lesions, where the lesion is. So we have to know that where the position of the upper lobe, or middle lobe, lower lobe, etc. So the left lower lobe position is this much, and left lower lobe in the lateral view is this. Next please. This is a case of horizontal fissure thickening. The horizontal fissure is thickened here. Next slide. Here we are seeing the Celauti sign. Celauti sign means Usually the the borders are clearly seen. The heart border is clearly seen. If there is a lesion here, the borders cannot be clearly seen. So there is a lesion in the same plate, so we cannot see the border. So if we cannot see the border, it is seen as it is said as a Speciality sign. This is a typical example of Speciality sign. We cannot see the clear border of the left heart border. This is a golden S sign. Golden S sign is usually it's a reverse S sign usually. Reverse S sign. This is a minor fissure. Minor fissure is collapsed upwards. Minor fissure is collapsed upwards, and there is a hilar mass. Hilar mass with upper lobe collapse. It is in these cases you can see a reverse S sign. This reverse S sign. This is the golden S sign. Next slide.
I think, ma'am, sorry to interrupt. I think the time is, we are running short of time, so kindly, you can take 1 or 2 more minutes more. Kindly make it fast. Dr. Benny, please note.
Next slide. This is a case of alveolar opacities. This is pneumonia. Air bronchogram is seen. Next slide. This is the air bronchogram. Here the air bronchogram is seen here. Next in the slide, the CT. Next slide. CT picture, air bronchogram is clearly visible. Next slide. Here is a case of bronchopneumonia. Next slide. Here pulmonary nodules are in most cases in metastasis. Here is a pulmonary nodules in aortic aneurysm. Next slide. This is calcification usually seen in a silicosis slide. Silicosis. Next slide. This is a popcorn calcification usually seen in hamartoma. Next slide. This is abscess. You can see in TB, carcinoma, lung mets, etc. Next slide. This is a cavity wall. This is a cavity. Next slide. This is bronchiectasis. Next slide. This is lung collapse. Next slide. This is ARDS, bilateral homogeneous this with the ground air bronchogram is seen. Next slide. This is pleural effusion versus consolidation. Here air bronchogram is seen. This is homogeneous opacification. Next slide. What is this? This is a miliary shadow. Miliary shadows less than 2 millimeter in diameter. This is a case of miliary tuberculosis. Next slide. This is metastasis, cannonball appearance. Next slide.
Can you conclude?
This slide is hydropneumothorax. Next slide is thanks. Thank you.
Thank you for an excellent presentation. Actually, you have covered most of the X-rays except COVID, I think. Nothing to worry. Actually, the COVID is one of the most commonly discussed topic now. Actually, excellent presentation. Thank you.
Bilateral ground glass opacities that usually seen bilateral consolidation. Usually we have all X-ray. These patients have bilateral consolidation or bilateral ground glass opacities with one side consolidation also there in some cases.
Okay, thank you. Thank you for an excellent speech. Next topic, we are moving to the next topic. It is a 2D echo, how to interpret it. This is this topic is dealt with Dr. Anand Marthanda Pillai. Actually, he is a very close friend of me, and he is a consultant interventional cardiologist and electrophysiologist at Anandaburi Hospitals and Research Institute, Trivandrum. He is an American board certified interventional cardiologist and heart transplant, fellowship in interventional cardiology, then fellowship in cardiac electrophysiology, and fellowship in cardiovascular medicine, then fellowship in heart failure and cardiac transplantation. He is an MPH holder from University of Illinois, Chicago. Welcome to you, and for this presentation.
Thank you for that kind introduction, Dr. Benny, and it is good to be back with friends. Dr. Shabir, thank you for the opportunity. Are you able to see my slides? I'll be talking on cardiac echo basics from a clinic perspective. A very basic review or an echo and how to interpret an echo report. So gone are the days when physicians would just send the patient to the cardiologist and have the cardiac issues taken care of without them knowing what is happening. Now it is a multidisciplinary approach. The physicians are very closely involved in ongoing cardiac care as well as follow-up of these patients. So because of which getting to know some basics about the echocardiogram will go a long way in terms of a comprehensive management of these patients as far as the internist and physicians are concerned. So when do you most commonly request for an echocardiogram? The most common situation is when there is a murmur, a pansystolic, ejection systolic, or a mid-diastolic murmur corresponding to a mitral regurgitation, aortic stenosis, or mitral stenosis. The second scenario is when there is a clinical suspicion of heart failure. Patients having exertional dyspnea, JVP is elevated, peripheral edema, you're suspecting systolic or diastolic dysfunction, and you want to know what the EF of the patient is like. Third one is coronary artery disease, when patient already has Q waves, as Dr. Arun had very nicely described in his talk, suggestive of old myocardial infarction. This could be a diabetic patient who might have had a silent MI in the past, and now coming with probably angina or heart failure. You want to get an echo and see if there is evidence of a myocardial infarction in the past. Hypertension, probably the most common cardiac disorder. A long-standing hypertension patients should have an echo to find out what degree of left ventricular hypertrophy they have and if they have any diastolic dysfunction leading to diastolic heart failure. Pulmonologist commonly wants to do an echo if the dyspnea is out of proportion to the pulmonary findings. And even in lung patients with chronic COPD and interstitial lung disease, you want to know if there is any evidence of pulmonary hypertension or right heart failure. So these are common situations when an additional echographic input is required in order to correlate the clinical scenario. I'll keep it simple as far as the echo report is concerned. The key things you need to know about is about, most importantly, the left ventricle size function. If there is evidence of regional wall motion abnormality, which we will talk about, evidence of LVH and diastolic dysfunction, at least a basic idea about the mitral and aortic valve, and evidence of right heart failure and pulmonary hypertension. So just to give you a sense of what we see in an echo lab, this is a parasternal long axis of the heart. You can see the left ventricle here, the right atrium, the left atrium, mitral valve in between, aortic valve in between, aorta, and this is part of the right ventricle. This is a parasternal short axis, a cross section. The heart looks like a donut, as you see here in these still images and in the pathology specimen. You can also appreciate the mitral valve here. This is what is called as a four-chamber view. As the name indicates, you can see all the four chambers, LV, RV, LA, and RA. So this is just to give you a visual appreciation of what we see in the echocardiography lab. So let's start with the left ventricle. All of us are, the key number we want to know about is the LVEF, or the left ventricular ejection fraction. You need to know what the normal is, which is around 55 to 65, and degree of systolic dysfunction. And EF corresponding to that is also important. Just remember 35, 45, and 55. Less than 35 is severe, 35 to 45 is moderate, and 45 to 55 is mild systolic dysfunction. So you should be able to correlate the degree of symptoms with the degree of LV dysfunction. Also important is the left ventricular size, because long-standing LV dysfunction can lead to LV dilation and remodeling, which is a very bad thing for the heart, going into progressive heart failure. And you need to have a sense of what the normal size of the heart is. So dimension-wise, heart should be less than 5 centimeters, which is the internal diastolic diameter of the heart. And in males, it should be less than 5.5. So chronic heart failure patients, if the heart size is around 6, 7, and 8, means that they are having very advanced forms of heart failure. Also important, this is again the cross section of the heart with these segments, anatomical segments, anterior, inferior, lateral, and septal. And why it is important to have an idea is because that corresponds to the blood supply, just like how Dr. Arun had described about the myocardial infarction of each of the territories. The anterior wall is supplied by the LAD, the inferior wall by the RCA. So let's talk about regional wall motion abnormality, which is a common term that you will see in the echo reports. As the name indicates, it indicates a regional problem in contractility of the heart, usually because of a myocardial infarction. And there is usually a very detailed explanation of the regional wall motion. We will talk about which segment is affected, which will corresponding to which artery is affected. The extent, base, mid, and apex of the heart is what you see here. So how extensive is the regional wall motion? And also we will talk about what is the degree. So we talk about hypokinesis when the contractility is less, and that is also classified into mild, moderate, and severe hypokinesis. If the wall is completely infarcted, it is called ekinetic, and if it is moving the opposite direction, it is called dyskinesis. So, and this is also has to be correlated with the total systolic function of the heart. So just to give you a visual appreciation of the regional wall motion, this is a normal heart that we saw before. Here, if you look at the anterior wall of the heart, you see that this wall is not moving much. So this will be an anterior regional wall motion abnormality corresponding to a myocardial infarction of the anterior wall from an LAD artery occlusion. Again, a cross section, you can appreciate that the anterior wall is not moving much. Again, long axis views corresponding to the same echo, showing a sluggish anterior wall. So you would also be familiar with another term which is called global hypokinesis, which, as the name suggests, all walls of the heart is not contracting well. Regional wall motion is only one or two of the walls, either anterior, inferior, or lateral. Global means all the walls are equally not contracting, and more commonly it is associated with a non-ischemic dilated cardiomyopathy, which tends to uniformly affect all the walls of the heart. So all the walls are equally hypocontractile. On the other hand, if there is a regional wall motion, it is more suggestive of a localized hypocontractility because of an infarction or ischemia due to one particular territory. So these two kinds of, this will give us a clue about the etiology of the LV dysfunction. So with wall motion is most likely ischemic cardiomyopathy LV dysfunction. Global is more likely a non-ischemic, but these are not exclusive, but I'm not going into the details. The next important thing to look at is to quantify the left ventricular hypertrophy in a patient with long-standing hypertension. Normal thickness is less than 11. Thickness, as it increases, you'll have mild, moderate, severe left ventricular hypertrophy. Why is it important? The thicker the heart gets, the stiffer it becomes, and that is what leads to heart failure with preserved ejection fraction, or a HEF, which is a increasingly understood entity. Particularly with patients with diabetic cardiomyopathy, also we are seeing heart failure with preserved ejection fraction. A lot of data has come out with the SGLT2 drugs. Most of these patients have actually diastolic heart failure. So that is an important type of heart failure which we are increasingly recognizing, and most commonly it is because of long-standing hypertension leading to LVH, leading to stiffness of the heart and causing heart failure. And that is also measured using an echo. The diastolic function is quantified as grade 1, 2, and 3 depending on the severity, and this is assessed from the mitral inflow. So most commonly you will see these gradations. And you can correlate that with the degree of hypertension, diabetes, and the heart failure symptoms. Moving on, we'll talk a little bit about the valve. Before going into the details, it's important to know what to look for when the patient is having a valvular lesion. So one, you want to assess the degree of valvular leak or regurgitation and valvular stenosis. But above that, you need to know what the impact of the regurgitation and the stenosis is on the left ventricle. So the regurgitant lesions like mitral and aortic regurgitation causes unnecessary back and forth flow of the blood, leading to what is called as a volume overload, which leads to LV dilation, systolic dysfunction, and systolic heart failure. On the other hand, aortic stenosis, where the heart is pumping against a high pressure because of a stenotic valve, causes what is called as a pressure overload, and that on the other turn causes hypertrophy rather than dilation, causes diastolic dysfunction and diastolic heart failure. So this is what you want to know when you're sending a patient with valvular lesion. One, want to know the degree of valvular problem and what the impact of the valvular problem on the heart is. So let's quickly look at a few of these. Mitral regurgitation. Looking at the valve, you will know why the valve is leaky. It could be a mitral valve prolapse or a rheumatic valvular disease. And you should know what the degree of valvular leak is, as well as the impact on the heart. A quick echo clip here showing a very floppy mitral valve, as you see here, and a very bright jet which is coming back into the left atrium, suggestive of severe mitral regurgitation due to a mitral valve prolapse. Mitral stenosis, all of you are familiar with advanced rheumatic valvular disease. Again, you want to know the degree of stenosis of the valve and other potential causes such as degenerative or congenital cause for the mitral stenosis, and what the impact on the heart is. So when the valve is stenotic, there is pressure overload in the left atrium, and the left atrium looks very dilated, as you see here, and there is also risk of atrial fibrillation and thrombus formation in the left atrium. Aortic stenosis, again, you want to know why the cause of stenosis. It could be degenerative senile stenosis or a bicuspid or rheumatic valve, and what is the impact on the heart. Echo will quantify the degree of thickness and calcification in the aortic valve, and as well as the degree of stenosis. Aortic regurgitation, why is it happening? Either because of a bicuspid valve, a rheumatic valve, or infective endocarditis. Severity of the regurgitant lesion, as well as the impact on the heart. Here again you see a floppy aortic valve with blood leaking back into the left ventricle. I'm almost done. Yes, I am done. This is my last slide. Pericardial effusion is a common finding, commonly seen in patients with hypothyroidism, as well as concomitant with pericarditis. You can have a pericardial effusion. Thank you.
Thank you, Dr. Anand, for an excellent presentation. Actually, echo is one of the commonly used tool for most of the cardiology diagnosis, and also in emergency setup, a lot of echo diagnostic tools were introduced nowadays. Thank you for the excellent presentation. Any questions regarding? Next, I am passing mic to Dr. Arun for introducing the next speaker.
Thank you, sir. The next speaker of the day is another close friend of ours, Dr. Anusha V, another product of Trivandrum Medical College. She was an MBBS 1998 admission student of Trivandrum Medical College. After her MBBS, she completed her post-graduation in ophthalmology from AIIMS with New Delhi with gold medal. And she is now currently working as a vitreoretinal surgeon in Shankara Eye Hospital. And she has numerous publications to her credit in index journals. She's a wonderful speaker, a great teacher. I have great pride in introducing Dr. Anusha V for her presentation on fundus examination. Practical tips. Over to you, Dr. Anusha.
Thank you, Dr. Arun, for that introduction. And at the very outset, I would like to thank my batchmate, my friend, Dr. Shabir, and would like to congratulate him for this online webinar, which has been excellently organized. And I would also like to thank him for making me a part of this conference or webinar year on year. So I'm here today to talk about the basics of fundus examination. Why is it really important? The fundus examination is important because it gives us a look into what is really happening inside the body. So I would concentrate basically on diabetic retinopathy. Are my slides visible? So we have some audience here. I'm taking this call from my hospital. So we've got our first year DNB students here also. So over to the topic. The basics of fundus examination, as I said, I would concentrate more on diabetic retinopathy because that is what is relevant as far as this conference is concerned. Diabetic retinopathy is responsible for 1.8 million of 37 million cases of blindness throughout the world. It is also one of the most common cause of new cases of blindness among adults 20 to 74 years of age. And during the first 2 decades of disease, nearly all patients with type 1 diabetes and over 60% of patients with type 2 diabetes have retinopathy. So that is the reason, that is why this topic becomes more important, because as diabetologists, if you screen the patient for diabetic retinopathy and refer to us at the earliest, early institution of treatment will prevent blindness. So before we know what is abnormal, we need to know what is normal and how we look at it. This is how the optic nerve looks like. These are the vessels arising from the optic nerve and dichotomously branching. And this is a fovea and this is a macula, which is responsible for vision. This is how in historical ages, this is how fundus examination used to be carried out with just a mirror to focus to converge the rays and the examiner holding another mirror. But thanks to the recent development, so now what are the different methods of examination? Now that we don't need to really hold a mirror in front of the patient, but so what are the other methods? One is a direct ophthalmoscopy. The second is an indirect slit lamp biomicroscopy, where we use a slit lamp and a handheld lens to sort of converge the rays and observe the retina. And the third is an indirect ophthalmoscopy. So this is a direct ophthalmoscopy. Why is it called direct? It is a direct ophthalmoscope as the image forms directly on the retina, and there is no intermediate image akin to that seen in an indirect ophthalmoscope. So what you see is what is formed as opposed to an indirect ophthalmoscope, where it is an indirect image. Charles Babbage was the first one to develop his practical ophthalmoscope. It was just a simple piece of mirror with a silver patch rubbed off from the center to make it see-through. And von Helmholtz is the first one to have described the optical working of an ophthalmoscope, and he is recognized as the inventor of the direct ophthalmoscope that we use today. Now, this is how we use it. So you need to go close to the patient. So obviously in this COVID era, we are not doing direct ophthalmoscopes as frequently as we used to do before. Now here, the light source from the batteries is reflected at 90 degrees using a mirror placed in the head portion. So this is how the ophthalmoscope is. And there is a mirror here and there's a source for light. When you turn on, the light goes on and you can sort of focus the light into the patient's eye. And the examiner looks through the hole. So this is how, before we know the abnormalities, again, it is important to know the instrument. All the diabetologists, medical specialists may be walking around with a small pocket retinoscope, ophthalmoscope, and this is how it looks like. So the front view, it has a reading window and it has the diopter disc to adjust for the refractive status. And this is a back view which has a reflecting mirror, and this is the aperture to adjust the light source. So the illumination system, and there's an observation system. The illumination system consists of a light source, condensing lenses which are inbuilt, reflecting prisms, and a series of apertures. The observation system consists of a peephole and a bank of spherical lenses, that is which is in the dioptric disc. So again, so the lens, you have to keep adjusting this till you get a clear focus. This goes on to the body, and this is the bulb in here which connects to the rheostat. There's a concave mirror with a hole in the center, and this is a peephole through which the examiner views. And these are all the different sizes. You can turn this so as to select the light, the filter, the grid, and all that. So this is, so this again is to adjust the power. This is to adjust the aperture, and this is to adjust the power. Now, what is the principle? From the observer, once you throw the light, the correcting lens focuses the light onto the patient's eye. The patient's eye reflects the beam of light. It is converged by a prism, which is focused again by a condensing lens, and that's how it works. So the methods of ophthalmoscopy is a distant direct ophthalmoscopy and a direct ophthalmoscopy. So before you go on to a direct ophthalmoscopy, you first see from a distance of 25 inches to see what the glow is, whether you're getting a red glow, whether the glow is altered. So the patient has cataract, or if the media is hazy because of a vitreous hemorrhage, then the glow may not be red. So you view the ophthalmoscope from 25 inches, you view the eye from 25 inches and look at the glow. If it's a red glow, you move on to the direct ophthalmoscope and you move closer to the patient. So first you look far away, and once you see a good glow, you go closer to the patient. The closer you go, you start adjusting your the dioptric disc so as to attain a clear view of the disc. So the steps would be to explain the procedure to the patient. You dim the lights in the room, and to examine the right eye, you must stand on the right side of the patient. Use your right eye to look into the patient's right eye, and for the left eye, it's the left eye. You stand on the left side and use the left eye. Now you select 0 on the lens dial. Place your index finger on the lens dial to enable you to change lenses quickly. And you ask the patient to look straight ahead and focus on an object in the distance. And then keep the reflex in view and move slowly closer to the patient. When you are about 5 centimeters away from the eye, the optic disc would come into view. So when the patient is looking straight ahead and you are focusing with your retinoscope, you slowly move your dial and go close to the patient such that you see the optic disc. Once you see the disc, you will see all the vessels emanating from it, and then you can see the discs and you can finally come to the macula. So when you see that optic disc, this is how it will look like. This is a normal optic disc. You look for the size, the shape, the color, the margins, and the optic disc cup to disc ratio. You can see that it is widened in a case of glaucoma. So this is a glaucomatous disc, and this is a normal disc. This is a normal cup, which is around 0.3:1 is a ratio of the cup to the disc. And here you can see it is totally, the disc is totally obliterated, and what you have is a total cup. Then you observe the blood vessels. You observe the diameter, the tortuosity, the color, the crossings, the light reflex, and also the AV ratio, which becomes more important, especially in case of hypertensives. The macula appears darker. It is around 2 disc diameters temporal to the disc. And this is what it is. The magnification that is offered by the direct ophthalmoscope is around 15 times. And you see about 15 to 70% of the fundus. So now we come on to some of the abnormalities that we might frequently encounter. Now this is, all of us would have learned earlier on that in hypertensive retinopathy, we get some AV crossing changes because of arteriosclerosis, which kink the vessels. So here there's different hypertensive retinopathy changes. You see that the arteries are sort of thickened off. You have a silver wiring or a copper wiring. You have this kinking of the veins. The veins have been kinked by the overlying artery. Again, you can see some arteriovenous crossing changes here as well. And this would give an idea that the patient has some evidence of hypertensive retinopathy. This especially becomes very important, especially in pregnant females when they look for effect of PIH on the eye. The next is the age-related macular degeneration. It's again a very, very frequent problem is seen in elderlies. So you can see a lot of abnormalities here. There is some blood here, and there's some exudates here. And this is another form wherein you can see multiple yellowish deposits all over the fundus. So this is the wet form, what we call, and this is the dry form. Again, it is responsible for visual loss. Early detection of all this would help us in initiating early treatment and again preventing visual loss. And hence I just covered all the important ones a little bit. Now we move on to diabetic retinopathy per se. What we need to know is whether the patient is suffering from any diabetic retinopathy at all, or if is it non-proliferative, in which case it could be mild, moderate, or severe, or is it proliferative, or does the patient have any macular edema, which is causing a decrease in visual loss. So this is a patient with mild NPDR, and this is what you would see. So once you ask the patient to stand in front of you, explain the procedure, ask him to look straight, and then look at the disc, and then move away from the disc onto the vessels. Along the vessels, you would see these small, tiny dots, white, red dots. And these are the microaneurysms, which represent the earliest stage of diabetic retinopathy. Since diabetic retinopathy and the kidney disease generally coexist, so with the onset of diabetic retinopathy, it is mandatory to screen the patient for a kidney disease as well, a diabetic nephropathy. Now, this is a slightly more advanced stage of diabetic retinopathy where you can see there are small white, these red dots here, but along with that, we also have some hemorrhages. So these red spots are the hemorrhages and these yellows are the exudates. So the diabetic retinopathy has progressed one stage up and it is now called a moderate diabetic retinopathy when you see these hemorrhages around. This is also a part of the diabetic retinopathy. These yellowish lesions are actually what we know as the cotton wool spots. They represent infarcts in the retinal nerve fiber layers, and they also are a part of the moderate diabetic retinopathy disease spectrum. Again, you can see that the exudates are there all over the fundus. You can see hemorrhages here, again exudates. So these are all cotton wool spots, hemorrhages, and this is what we know as a succinate retinopathy because of those microneurysms which are leaking. Now, then we have the severe or the very severe NPDR, which is a little ominous, and it signals the onset that the patient can move on to a proliferative diabetic retinopathy very quickly. So at this stage, we really need to intervene, evaluate the patient systemically, as well as from the ocular point of view, and initiate treatment that would be pan-retinal photocoagulation or ocular laser. So this is what you see as some vessels which are abnormal, which are arborizing. There is no definite pattern to it, to which we call as an intraretinal microvascular abnormality. So there's a 4-2-1 rule where if you have 4 hemorrhages and microneurysms in all 4 quadrants, if there is venous beading in 2 quadrants, or if there are these intraretinal microvascular abnormalities in at least 1 quadrant, it could contribute to a severe or a very severe NPDR. So this is a venous beading which I was talking about, and you can see these very, very fine and tortuous vessels, which is actually the IRMA or the intraretinal microvascular abnormalities. You can see the venous beading also here. So this is how venous beading looks like. This is another patient, a diabetic patient with a visual loss, and what you would see is the presence of these hard exudates, and this is responsible, along with the amount of fluid, responsible for visual loss, and this contributes to diabetic macular edema. Again, this is an investigation that we generally do for patients with diabetic macular edema is a fundus fluorescent angiography, wherein you can see these small leaking aneurysms here. What you can see as these small red spots are now throwing up fluid, which is responsible for the visual loss in macular edema. The last, or the a serious manifestation of diabetic retinopathy is a proliferative diabetic retinopathy, where you could have a neovascularization of the disc. You could have the presence of new vessels elsewhere on the retina, some pre-retinal hemorrhages, vitreous hemorrhages, and retinal detachment. So this is how a proliferative retinopathy looks like. And this is the presence of new vessels over the disc. You can see them proliferating all over. They look very, very angry. The presence of new vessels here. Again, a lot of vessels arborizing randomly. Again, here you can see these hemorrhages. These vessels they're very, very flimsy. They can bleed at any time and can lead to visual loss. You can see these vessels have now bled, and the patient now has some amount of bleed which is developed here and here. So this contributes to proliferative retinopathy, which is again a very advanced stage of diabetic retinopathy. Another manifestation is a vitreous bleed, where it is just not confined to beneath the retina, but comes out, the blood comes out into the vitreous and leads to vitreous hemorrhage and visual loss. This is a form of tractional retinal detachment, again an advanced stage of diabetic retinopathy where the retina itself is detached, and you can see these numerous angry looking vessels which are pulling onto the retina and causing it to detach. Again, the presence of new vessels in the iris, again, is an end stage contributing to glaucoma and an absolute eye, which is the neovascular glaucoma causes the eye to become painful and red, the intraocular pressure rises, and it leads to loss of vision. So again, to summarize, this is a relatively good-looking fundus. You can see these small red spots here and there occasionally, so it would be a mild non-proliferative diabetic retinopathy. Here, slightly more than that, but you see some hemorrhages, some white dots, some hard exudates scattered all over. So this would be moderate diabetic retinopathy. There are some flame-shaped hemorrhages all around the fundus in almost all the quadrants, so this would be a severe NPDR. And this is what would constitute a macular edema, where you can see these hard exudates around the macula and the fovea. In this page, this is the kind of patient who would present with visual loss. The challenging part of it is that patients with proliferative diabetic retinopathy with the NVD might still have a vision of 6/6. So unless the patient is screened early, the patient can bleed at any stage with resulting in visual loss. So again, this is a patient with a florid NVD, and here you have vessels elsewhere. So this is NVE. There are a lot of hemorrhages here. So there is a pre-retinal hemorrhage, and it has caused severe traction on the retina, pulling it, resulting in a tractional retinal detachment. So another method of evaluating is an indirect ophthalmoscopy. That was a direct. Again, this is used to screen for diabetic retinopathy after dilatation. Here you use a headband, you use a condensing lens, and it is used to foresee inside the eye. There are other modalities to image the eye, such as a fundus fluorescent angiography, an optical coherence tomography, which evaluates the retina. It's like it's like a CT scan of the eye, which gives you a slit of the different sections of the eye and evaluates for the presence of any underlying disease. An ultrasound, which picks up the presence of any diabetic vitreous hemorrhage. Now, this is how a patient is treated with proliferative diabetic retinopathy. We need to treat with laser, and these are how the laser spots are administered, and this is how it looks like. So these are the fresh laser spots, these white spots, and these are the black marks are the old laser marks. So this is how a patient treated with diabetic retinopathy or proliferative diabetic retinopathy looks like. The treatment would involve the presence of anti-VEGF injections or surgery, which can be done only if the patient is detected early or screened early, referred early, and the treatment is initiated early. So what's my take-home message is, all of you there who general medical practitioners, diabetologists, please do get a retina examination to see what diabetes is doing back there, because it's important to prevent complications, which can be done with early detection, early treatment, even when asymptomatic, by routine fundus examination following referral to an ophthalmologist. Thank you so much.
Thank you, Anusha, for an excellent presentation.
Thank you, Dr. Ben.